for those of you that attended, there we go. For those who attended the previous lecture, I wanted to make it sure as to have it more systematic in the sense that everything is normal in the first one, and in the second one I wanted it to be so that we discuss the pathologies and try and go for sort of again the systematic approach itself in trying to describe or interpret the X-ray itself. So let's get started with that. So basically, the objectives of this lecture is to recap on what do I mean by systematic approach in terms of interpretation. So what you need to cover whenever you're reading an X-ray. Now, I did mention this last time as well, but for those of you who weren't there last time, there is no single approach when you are looking at a chest X-ray. There are many types, there are many ways of starting or finishing an X-ray, but the main thing is that all parts of the X-rays are covered. All parts of the X-rays is covered, and by that I mean all the different features that you see, from bones to soft tissue to viscera to air to subcutaneous tissue, as well as any kind of abnormal pathology and abnormal foreign bodies as well that might be present. Now, we're going to start off, and this is for you particularly at, I'm going to give you an X-ray and you're going to describe that X-ray and you're going to describe your interpretation of what that X-ray is. Just by yourself. You don't have to share it with me. You don't have to share it with myself. You don't have to share it with anyone else. And then we're going to go through all the different pathologies that we can, that are very highlighted on chest X-rays. Remember, chest X-ray modality, it's a very quick modality, but at the same time it's not the best modality. It's just fast, and therefore you can spot acute stuff very quickly. And then I'm going to give you that same X-ray that I'm going to show you at the start, and I'm going to ask you to interpret that or describe your interpretation again and see how different that is, basically, after you've kind of spotted these various pathologies and seen what all you're meant to look for. And finally, there'll be some tests. So at the very end, there'll be a lot of X-rays that we'll go through. I'm going to give you a couple of minutes in each slide, and just to spot the really quick, obvious abnormality that you see in it. Okay, so what do we mean by the ABCDEF system? Can anyone remember? If so, just put it on the chat. So what do each of these letters stand for, basically? And can anyone remember the systematic approach that we discussed last time of how to interpret these X-rays? You can unmute yourself and say it as well if it takes too long to type.
I'm happy to talk.
Go on.
Yeah, so I wasn't here last lecture, unfortunately. I didn't know.
That's okay.
But I've heard of the ABCDs before.
Good.
So I think A was airway, looking at the trachea, looking if there's any deviation in the trachea or any foreign bodies like a coin or something. B would be bones, so just the ribs and the clavicles. Maybe sometimes they even evaluate the shoulder girdle a little bit. C would be the cardiac silhouette, just looking at the mediastinum.
Perfect, yeah.
D is probably the diaphragm, and I don't think I don't know about E. You said F also.
F as well.
So
what do I mean by F? I know it's a bit of a weird one to have an F at the very end because it doesn't really relate to the organ in question that we're looking at, and the obvious organs that you can see on a chest X-ray, or the ones that are so big, are of course the
just the lungs and the mediastinum, the bones, the great vessels, the hila of the lungs, the tip of the diaphragm, maybe the liver, and sometimes a bit of the stomach as well.
Yeah, yeah. So basically F, it just stands for fields. So it stands for lung fields, or you can call it lung zones as well if you want to. The reason why is because we don't really tend to go by lobes when we're talking about lungs, just because we can't really appreciate the different fissures that well on chest x-rays. On a CT, yes, we can, but not on x-rays. But before we do all of that, we have to make sure that we, yeah, it is field, Sarah, yeah. But we have to make sure that we have to we have to make sure whether the chest x-ray itself is valid and it's of good quality. I mentioned about validity and quality last time as well. So, you know, a couple of points would be if it's a PA, if it's an AP, if it's a good quality chest x-ray in the sense that are all the main, all the main points covered. So for instance, can you see the first ribs? Can you see the diaphragm? Can you see the costophrenic angles? Can you see the edges of the pleura? These are the main things that will kind of allow you to proceed to get an accurate interpretation of the x-ray itself. But apart from that, you did a really good job at describing. So like you mentioned, A's for airways, B's for bones, but also soft tissues as well. Remember, there's also a lot of fat tissues. There's also a lot of connective tissue that's involved. Like you mentioned, the cardiac silhouette and the mediastinum. The diaphragm and the gastric bubble, they usually go together. E is, you're close, it's for the pleural effusion. So usually we kind of talk D and E together because you kind of, they are kind of similar, because at the end of the day, if there's any kind of blunt of the costophrenic angles, it is due to some kind of effusions, and the costophrenic angles are evaluated as part of the diaphragm as well. And finally, the fields. So these are all what we see as, well, normal findings on the x-ray. When I mean normal, I mean even if they're pathological, they're still parts of the human body. But in addition to that, at the very end, we always have to check other features. And by other features, I mean lines, I mean tubes, I mean devices that are sort of artificial, you know, like for instance, pacemakers or any kind of changes that are caused due to surgeries as well. Okay, so that's basically a recap of what system of what kind of a systematic approach to kind of start your interpretation really. Now, so this is an x-ray that I'm going to give you. So just write down how you would want to interpret this from the very start. I'm just going to give you a quick 5 minutes, okay? And I want you to write down your most accurate interpretation of this x-ray. Now, to save you some time, I'm going to let you know that this is a PA x-ray. It is of good quality. It is definitely valid. And I want you to go through your systematic approach, whichever it might be. You don't have to follow the ABCDF system if it's not for you, if it's not for you. I want you to go through this x-ray. I want you to tell me, or write down what it is that you see here, and potentially even try and come up with a diagnosis at the end. So I'm going to give you 5 minutes. You don't have to share it with me just yet. But once we are done with the pathology section, we'll come back to this x-ray and see what it is or how it is that your interpretation has changed. So 5 minutes, or maybe, you know what, just 2 minutes. You have to be quick at this. All right, I think that's enough now. So I hope you've written a good interpretation of what it is that you see over here. And we'll see how that has changed after we go through the pathologies and how you would want to describe them afterwards. Okay, right. So like I said, also, just to reiterate, this lecture is predominantly only going to focus on all the abnormalities that you're going to see. So you're not going to see normal things, which will kind of make your life a bit easier because there'll be something abnormal in any of these x-rays. Right, with airways. Now, airways can be three things. They can either be narrowed, they can either be deviated, or they can contain foreign objects. Okay, there's nothing else to talk about airways, or not, there's nothing else to look for in airway apart from these things. If they are dilated, that's actually a good thing. It's not a bad thing. Okay, and we don't really pay too much attention, particularly when it comes to chest X-rays regarding that. So we have a case. All right, we have a 4-year-old boy. He's normally fit and well, engages really well with parents. By that I mean he is socially quite interactive with his parents. There's nothing wrong with him. However, the past couple of days, he's developed a fever and a cough. There's no weight loss. There's dyspnea. There's no hemoptysis. And these symptoms, they don't really respond to any conservative measures. And the GP, once he saw this boy in the, so they had a telephone consultation first, and the GP initially said, just, warm water, no need to give antibiotics. After a couple of days, they actually went in and the GP saw him. The GP was like, okay, you know what? You need to go to pediatric A&E. And the pediatric A&E shows this kind of an X-ray. Now, this is obviously zoomed in, okay? Anyone know what you're looking at over here? Again, you can just unmute yourself, or you can just type in chat. Exactly. Not a narrow larynx. Larynx is more above this. Not tracheomalacia. I think we already had the right answer by Moina. It is a Steeple sign. Okay. Now the Steeple sign. Does anyone know what the Steeple sign it corresponds to? What is it? What are we talking about when we're talking about the Steeple sign? Yeah, it is true for tracheoma. Yes, that's correct. It is croup. Okay, it is definitely a croup. Now, what is it? Does everyone know what croup is? Just before we carry on. I'll get back to you on why I think that this is not just epiglottitis. Okay, because epiglottitis, it requires another type of symptom as well, and it presents usually with one other symptom, and it presents usually in older children. Okay, yeah, it is essentially laryngotracheobronchitis. Exactly. Yeah, exactly. It's a barking cough. Well done. So the main thing is you have to relate this to the picture. Okay, what I mean by that is that even though you can see steeple signs even in adults, and the thing is, what you find is that many people actually call this out in adults. You don't really have to worry about it if it's in adults that much, because croup is not really an infection. Yeah, exactly. Well done. It's not really something that presents itself in adults as much. It is definitely something worrying in children because, as you mentioned, it is barking cough, so you do have to treat very, very quickly. And you have to, it is an emergency at the end of the day. So this is a simple example of, it is a medical emergency because, you do have to treat it. Otherwise, it'll only get worse and worse and worse. Now, someone mentioned epiglottitis before. Okay. Now, the main differences here are that there is another symptom, and that is dysphagia. Okay. You need to have dysphagia as well for epiglottitis. And you also, it usually presents in older children. Okay. But the main thing over here also is that they're all non-specific symptoms. Yeah, they're all non-specific symptoms. So therefore, you still have to do an X-ray regardless. And in this case, what we do is, as Amir mentioned in the chat, you do a lateral X-ray, and this is what you see. You see this specific sign. Does anyone know what sign this is? Amir's shaking his head. He's racking his brain over it. What does it look like to you? All right, I'll put you out of your misery. It is known as a thumb sign. Okay, it's known as a thumb sign. Now, why is this an emergency? Why is this more of an emergency than the croup? Does anyone know? Yep, it's definitely more inflammatory. Okay, fine. But why is that Yeah, exactly. It is fast progressive. Yeah, it's very, very progressive. And why is it? There you go. It is acute respiratory failure that is life-threatening, because you can essentially seal off the entire airway, and that will just result in complete respiratory failure. It'll result in cyanosis, and then it'll lead really quickly to death. So what would the treatment for this? How would you initially manage this kind of, if you see this on X-ray, what's the first thing you'd automatically do? Well, you should do this even before, but what would you do first? Okay. Intubation. Yep, exactly. You definitely do intubation. You give them 100% oxygen, intubate them. If at all, you know, if it's getting far worse, then you try and do tracheotomy, try and give them any kind of tubes through so that they can actually get the air and refill or re-expand the lungs. So yeah, so this is an actual emergency. Yeah, exactly. And antibiotics as well. Okay, that will come in much later once you've stabilized the airways, you've stabilized the saturation, you've stabilized the blood gases. Okay, but yeah, these are the two main emergencies when we're thinking about airway narrowing. Okay, now that's all to do with narrowing. Let's focus on deviation. Now, what do I mean by deviation? Deviation itself, you need to establish whether there is a pull force or a push force that's causing this deviation. Okay, there are some diseases that cause a pulling effect because they cause a lower pressure to develop on that side of the body, creating the pull effect itself on the airways. At the same time, there are some pathologies that cause a push, creating a higher pressure, and that'll push the airways away from that side of the body. At the same time, we have to also figure out whether the trachea deviates towards or away from the affected side. Again, there are several pathologies that cause this as well. Now, what do I mean by this? Now, let's take an example, pneumothorax. Okay, so pneumothorax, I mean, you all should know this, you all definitely know this, is basically when there is some kind of air in the intrapleural space. Okay, oftentimes this happens because there is some kind of breach in the chest wall, or sometimes in long, thin males, it's very, very common that it happens because you have sudden ruptures of the alveoli network, and therefore you have air going the intrapleural space itself. And the reason for why it can get worse and worse is because the atmospheric pressure is higher than the intrapleural pressure, so you get air buildup over there. Now, this in general affects only one side of the lung, and obviously, if at all it results in tension pneumothorax, it becomes larger and larger and larger and larger. And when it does that, it creates a higher pressure. This higher pressure will then cause a push effect on the actual airways that will then deviate them away from the affected side. Quite contralateral. Well, the other side of it is basically, in the opposite end, is if at all we have an example of pulmonary fibrosis. Does everyone know what pulmonary fibrosis is? Yes. Okay, good. I can see Amir I can see Amir nodding his head, so we're good. Basically, this usually happens bilaterally, but just for the sake of this argument, imagine if this happens unilaterally on one side. Let's just say that this side is the left side. Okay, basically this will result in the lungs losing the ability to expand and contract. At the same time, they'll start to shrink. When they shrink, they'll drag the pleura with them. So what you're creating is a negative or lower intrathoracic pressure on that specific side. Okay, so when you're creating this negative pressure, the trachea will automatically deviate towards the affected side. So this is what I mean. So there are these pull and push forces, and at the same time, the deviation of the trachea will depend upon pressure predominantly in these pathologies. But I'm not saying the pressure is the only thing. You also have masses that come into the play as well. Okay, so pressure and mass effects are the main causes of deviation of airways. Right, what do we have here? I want you to tell me what we actually see on the left side and what we actually see on the right side. Okay. Okay, fine. On the left, there is tracheal deviation towards the right lung. Okay, fine. And what about the X-ray on the right? Okay. And why might there be a tracheal deviation towards a left lung, if there is a left lung there? So Amir is quite right in saying that on the left X-ray, there is definitely a deviation away from the side that is affected. And the reason why is because there is a high pressure on the left-hand side that is causing this deviation towards the right side of the body. And can anyone tell me why there is? I mean, you've already said it's fluid. So what do we call that? What do you call fluid in the thoracic cavity? It's not necessarily a fluid. Effusion, pleural effusion, exactly, pleural effusion. Pneumothorax will not look like that. Pneumothorax will look black. Okay, so just pointing that out. I'm sure you knew that. Okay, so on the right, yep, pleurothoracic. On the right, there is an abnormality, okay, that is causing low pressure. And in this low pressure, the reason why, can anyone tell me why there might be low pressure on this side? What are the things that you know of that can cause a lower pressure of the lung? What will result in lower pressure of the lung? Yes, blocked bronchus. So that means basically if there's any kind of a mass that will result in a blocked bronchus, that will then cause the alveoli to deflate and thereby not actually suck in the air, and thereby it'll create space. Other causes can also be, for instance, if the lung itself is taken out completely. Okay, think about, you know, a complete pulmonectomy or even a lobectomy. Okay, these will all cause low pressures and it'll cause deviations of the trachea to the side that is that the lung is not there anymore. Yeah, exactly. It would look much darker. Exactly. Okay, fine. Now, what can other cause of deviation be? So this is what I mean by the mass effect itself. So by mass effects, I just mean local displacement. Local displacement itself can then be translated into either if there is any kind of mediastinal or high lymphadenopathy, usually due to malignancies. The most common malignancies are obviously going to be any kind of thyroid mass, any kind of lymphoma, carcinoma. By carcinoma, I mean breast or other forms that can persist over there. Or it can also be due to anything to do with the heart itself. And usually the heart will display its own features without affecting the airways too much. There's one particular feature which is known as the splaying of the bronchi. Does everyone understand what splaying of the bronchi means? That term? No, we'll get to that. There's one specific feature or one specific pathology of the heart that will cause this feature to appear, and that is left atrial enlargement. Now, what do I mean by that? So in this X-ray, what can you see? So tell me where the actual deviation is and why there is a deviation that you can see here. First of all, is there a deviation? Trick question, there is a deviation. So there is a clear deviation. I'm going to try and get the laser out. So there is a deviation right here. here. Okay, why is it still there? There's definite deviation of the trachea towards the left-hand side. And the reason for it is, as you can see, on the right-hand side, there is a massive lesion. Anyone want to guess what lesion that might be? Yep, and the right apex is a massive lesion, exactly. Very, very close. It could be a thymoma. Now I'm going to say if we're talking about a 20-year-old, 25-year-old person, can it be a thymoma still? Could be a germinoma as well. Very, very, very rare conditions you guys are going to. I like this. I really like this. Always think common is always common. We're not going to see thyroid carcinoma. Exactly. Thyroid. That is the most common thing that you will see. Thymomas are very rare. Germinomas are very rare. Anything else you think about is very rare. Okay. Common is always common. So in this case, it is a thyroid cancer or thyroid goiter that's causing this deviation to the right, okay, to the left. Okay. Right. Let's go on to the next one. What do you see here? First of all, is there a deviation of the trachea? Good. Okay. There is definite cardiomegaly. Okay, I'll give you that. It does look well done. Whoever said massive left atrium, Amir, that's you. Well done. Why do you think there is a massive left atrium? What are the features that you can see on the airway alone? On the airway alone. Okay, good. We're getting ourselves safe. Just focus on the airways. So this is essentially what I meant by, yeah, good, good. There is slight deviation to the right. Yes, there is. But the main thing is we can see this. Okay. Now this is not normal. Yes, the left is always, it should be more horizontal than the right, but it shouldn't, the angle, the coronal angle is what we call it. It shouldn't be this much. Now, the reason why it shouldn't be this much is that this angle over here is more than 90 degrees. Shouldn't be more than 90 degrees, should be less than 90 degrees. Okay. And this is the definition of what I meant before. There is splaying of the bronchi. Okay, splaying of the bronchi is one of the characteristic signs of left atrial enlargement. So yes, you're right if you say that there is cardiomegaly, absolutely. But bear in mind that you have to first identify what other causes or what can cause this cardiomegaly. So in this case, it's more likely to be left atrial enlargement. Remember, cardiomegaly cannot be as easily differentiated from pericardial effusions, whether it is right ventricular enlargement, whether it's left ventricular hypertrophy. You can't really distinguish that easily from a chest echo. So you need to pay attention to the symptoms and other features that might be present for you to evaluate what it can be. Okay, so in this case, because of the splaying of the bronchi, of the coronal angle, it is definitely left atrial enlargement. Now, the final thing to do with airways is foreign objects. Now, foreign objects can present in young as well as old patients as well. They're typically hyperdense objects, so you can easily pick them out. Quick question, what side is more common? What side would the foreign object be present in more often? And why? Exactly, on the right-hand side. And why is that? Okay, closer branching. Good. And yeah, it says less steep, but you're right. It is definitely on the right-hand side. The reason why is because the right main bronchus is far less horizontal than the left main bronchus. Okay, so that is exactly why you'd find more and more objects to be dislodged in the right side of the heart, right side of the bronchus rather than the left. And what do you see over here? It's a very obvious sign. It's a very obvious anomaly that you can see over here. A tooth, exactly. So this is usually typically in older people. You won't find this kind of stuff in younger individuals. In younger individuals, you'll probably find coins or things that usually you can make IKEA furniture with, maybe. But in this case, it's definitely in older people. Okay. So there you go. That's the actual anomaly itself. Now let's get to the bones and soft tissues. Does anyone want to tell me what are the features of the bones that we want to look for? What are the features that we should try and evaluate for in the bones? Fractures, good. What else? Yeah, clear edges for sure, to see if the parosteum is actually clear or not. What else? What else are we looking for on the bones on the chest X-ray? Good. So metastasis, good. So metastasis can be of two different kinds. We'll get to that as well, but that's good. What else? First of all, let me ask you this. What bones do we want to evaluate on the chest X-ray? The ribs, of course, we have to evaluate the ribs. What other bones are there? Clavicles, good. What else? Yeah, you're right. Shoulder dislocation, yeah, but at the same time, and the spine, exactly, the spine. Now, those who attended my last lecture will know how important it is in terms of, or to evaluate the rotational aspect of a chest X-ray. And for that, and as well as the rotation, we have to also look at the penetration of the X-rays and whether it's of adequate penetration. And for that, we always look at the spine. We always look at the spine or the shadow of the spine through the heart in order to see how good quality of the X-ray we get. So we definitely look at fractures. We look at deformities, okay? We look at sclerosis as well as lytic lesions. So by sclerosis and lytic lesions, I mean metastasis, essentially, okay? Because metastasis can present as osteoblastic or osteolytic metastasis, okay? And finally, this, I'm just putting it in there because of completeness, osteopenia. Now, osteopenia is not really something that you would look into at a chest X-ray for. It's really hard to identify because in general, the ribs, the clavicle, and the humerus, it can't really be evaluated chest X-ray, but you generally look for the spine, but you need to have a lateral view of it, and more likely you'd need to look at the lumbar X-rays for osteopenia, as well as a pelvic girdle instead, because the density of the bones in the upper part of the body, they are generally lower, so you can't really tell that much. Okay, so in terms of fractures, we can divide them fractures. We can divide them into old or new fractures, or we can divide them into symptomatic versus asymptomatic, okay? Now, let me just give you an example. These are obvious fractures. Can anyone tell me, number one, the location of the fractures? There are 567 fractures. Okay, that's good news. Yeah, you're right. They're ribs. Exactly. Well done. But you have to be a bit mostly described as anterior ribs and posterior ribs. In this case, are we talking about the anterior ribs or the posterior ribs? Well done, posterior ribs. Why are we talking about the posterior ribs? What gives that? Why do you say they're posterior ribs rather than anterior ribs? Good, the angle. But at the same time, a good way to remember is that the posterior ribs are more prominent. They're easier to spot. Okay, and the posterior ribs are more horizontal. Okay, the anterior ribs come at an angle that's more oblique. So you're right, it is definitely. So let's have a look. So 1's here, 2's here, 3, 4. Yep, 5, 6, 7, 8 as well. And let me just move the chat box to one side. There is a little bit of a fracture on the 9th, but not too much. But yes, that's absolutely right. So 5, 6, 7, 8, and a little bit of 9 as well. And that's the way you're meant to describe as well. So posterior ribs, describe the number, describe the location of its lateral. Okay, so in this case, we can say the 5th one is medial, closer to the costovertebral angles, whereas the latter ones are more lateral, lateral posterior ribs. Okay. Anyone want to guess at what might be the cause of it? What could be the cause of rib fractures? Trauma, exactly, trauma. Okay, high energy trauma, exactly. Blunt trauma, if you want to be even more specific, but that's well done. High energy trauma. Good. Okay, what's the treatment for this? Is there a treatment for this? How would you manage someone with rib fractures? Good. Well, I mean, you don't do nothing. Yeah, painkillers, exactly. Good. You just give them painkillers and hope for the best, because you can't really do anything with it. You can't immobilize it. You can't do anything because, well, the ribs are meant to expand and relax. If you restrict that, then poor guy won't be able to breathe. So now we have an X-ray over here. Can anyone try to identify where, if at all, there is a fracture? And can anyone tell me the location, the number of the rib that is affected? And, oh no, there we go, okay. Hopefully no one saw that, but can anyone tell me the location and the number? Fourth posterior rib. Which side, left or right? Right. No, there is a bit of, I'd say there's indentation, but I wouldn't say there is a fracture. There isn't an actual fracture. You can't see any kind of hyperdensity that is associated with a fracture. Okay. So 7th on the right. Okay, right means left. So 1, 2, 3, 4, 5, 6, 7. Posterior, anterior. Let's see who said 9th posterior. Okay. Amir, I think you won this one. It is definitely on the left 9th posterior. And I'm just going to zoom into that, okay? Here we go. You see how subtle this is, this breakage of the bone itself. It is very, very, very subtle, okay? Now, quick question. Who would know that there is a fracture over here, and what might be the symptoms that they can present with? Yep, on breathing. It's just left-sided chest pain. Exactly. That might be a pleura rub. Yep, exactly. But apart from that, nothing else. So it's very, very hard to identify fractures that are so subtle without the actual symptoms at all. Okay, so this is one of the subtle fractures. So we have another case now, guys. 34-year-old male, chest pain, ECG is normal, TROPs are negative, no recent history of trauma, okay, as recollected by the patient. On palpation, there are no lumps or tenderness. On the family history, father has got, ischemic heart disease. Paternal grandfather apparently had hypertrophic cardiomyopathy towards the end of his life. That's all you get. And because of the chest pain, we've done a chest X-ray like this, and it's showing this. Remember, he's only 34 years old. What can you see over here? Can you see anything over here? Go through each pair of ribs individually, starting from number 1. So pain. Hang on, let me just go back again. There you go, just chest pain. Okay. On palpation, there's no lumps or tenderness. ECG is normal, TROPS negative. Why would you say osteomyelitis? Where can you see evidence of osteomyelitis? Yeah. Okay, fine. But where? And also, wouldn't osteomyelitis display inflammatory symptoms? Would it not display fever? Would it not display systemic kind of pathology as well? So I'll put you out of your misery. So this is usually an incidental finding. Okay. Now this person has got nothing wrong with him. He's not able to recollect if at all he's had an injury or not. Yeah, definitely a fever at least. Yeah. So in this case, I want you to look at, on the right hand side, I want you to look at the ninth. No, there's no pneumothorax here. Look at the pleural lining. It's still all the way towards the edge. There's no pneumothorax over here. It might be a mild one actually, now that I mention it, because the lung is a little bit compressed over there, but that's not a significant aspect of this, because he's not displaying dyspnea, or we didn't really record his saturations as low or anything. Now, in this case, the right-hand side, I want you to look at the ninth posterior rib. Now, an easy way to show you that is if I get the spotlight out and over here. Okay. To describe this is going to be a little bit hard, but a good way to say it is, number 1, it's an incidental finding. It's a little bit dilated, but we don't really describe the term dilated. They use the form callus formation. There's mild sclerosis. There's also something called cortical buckling. Okay, that's what we use, because there's an actual change in the continuity of the bone itself. And this is very characteristic of a chronic fracture. Okay, the previous 2 that I showed you was more acute. You can actually see the fracture itself. In this case, the fracture has kind of healed itself, but you can still see there's a little bit of a gap over there. And if you paid a little bit more attention, there's also a little bit of a gap in the 8th posterior middle part of the rib as well. Okay, so these are all chronic fractures that are trying to heal. Okay, right. Next one. The last thing, and this is very, very obvious, are clavicular fractures, and they're just described based on location. Now, quick question. Is this an AP view or is this a PA view, and why? Why is it a PA view and not an AP view? It is an AP view. One of the main things to look for is how horizontal the clavicles are. They're very horizontal. It's more likely to be an AP view than a PA view, or oblique. Okay, so in this case, it's very, very simple. It's a standard clavicular fracture. No messing around over here. But generally speaking, the clavicular fractures are a lot more obvious as well. Okay, right. Deformities. Now, what do I mean by deformities? Deformities of bones can be, there's a multitude of them. I'm not going to go through every single one because we'll be here forever. Things that you need to look for on a chest x-ray are, they involve the spine. We always check for deformities of the spine. And there are two types of deformities that we look for. And can anyone tell me actually what deformities of the spine there are? What are we thinking about when we're talking about deformities of the spine? Good. Excellent. Kyphosis and scoliosis. Well done. Okay. We'll get right into this one then. Okay. Spondylolisthesis is there. Yep, you're right. But it's not. Yeah, there are lateral body deformities as well. But remember, you have to pay attention to what kind of modality we're using. We're not using a CT. We're using an X-ray. Okay, you're right. Those are all valid deformities, but they're not. Well, an X-ray is not diagnostic for them. Okay. So with scoliosis, how can you describe this? What kind of scoliosis can you see? What would you call the scoliosis, first of all? So, okay, this is not kyphosis. This is scoliosis. What's the difference between kyphosis and scoliosis? So scoliosis is more when we're talking about the curvature of the spine. Yeah, is more the curvature of the spine going along the y-axis when we're thinking about a coronal view. Okay. Whereas when we're talking about the kyphosis, it's more towards a sagittal view orientation. Okay, so in this case, we're talking about an S-shaped thoracolumbar scoliosis with the convexity to the right hand. Anyone know? There is an angle that you can also see on the X-ray. It says about 25. Does anyone know what angle that is? Yes, well done. Good, very well done. It's a Cobb's angle. What does that mean? What's a Cobb's angle? Yep, it definitely does sort of measure the degree of scoliosis. Well done. And why is it so important? Yep, the severity and the management. And what do you know about the actual management? What do we do when monitoring progression? Well done. Well done. That's a good way as well. So in this case, what would you do? The Cobb's angle is 25. What would you do? No, yes, you're right. You would definitely call ortho. You definitely have to do an orthopedics referral, but in the UK anyway, the angle should be more than 30 in order for them to even consider surgical intervention. Until then, we only manage conservatively. I know it's really, really bad when it comes to that, but as you can imagine, the pressures of that ortho is on, it's quite a lot. Okay. Right. Moving on, what do we see here? So this should be a very, very, very obvious kind of an X-ray to you. Good. There's hyperkyphosis. Well done. What else? What's really, really weird about this X-ray or pathologic, I'd say, of a specific kind of condition? Not bamboo spine, close. Bamboo spine is something different. We can get to that as well, but there is definitely hyperkyphosis. Wouldn't call it a rib hump? No, but there is definitely a way to describe this sort of a chest. Good. Whoever said barrel chest, they're the winner. It's a barrel chest. Okay. And what are we looking for in terms of barrel chest? How do we define a barrel chest? Like just from a clinical view, when you're looking at someone, what would you think that this is definitely a barrel chest? Good. The AP diameter should be equal or nearing side-to-side diameter of the actual chest wall itself. But on a radiological context, we have to also make sure that there is definitely some sort of kyphosis, which you can see very well in this X-ray. Now, you said it's, there's a greater AP diameter. There's definitely hyperkyphosis. So, can anyone tell me what the diagnosis can be? Good. Emphysema or leading to? Good. Advanced COPD. That is basically what this person's got, and it is quite bad. Okay. Right. Sclerosis. These are, now we're getting into more about the density of the bones and whether or not there are systemic conditions. Okay. What is sclerosis? Yeah, if you're a man, for sure. So what is sclerosis? Bone buildup, hyperdensity. Well done. Okay, what can cause sclerosis? Now, I just want you to think about, the broader causes, not just, focusing on just one specific pathology. I just say, oh yes, you know what, there's definitely prostate cancer. Think about all the other things that can possibly cause. Yep, inflammation. Well done. And I think you mentioned this before as well, which is osteomyelitis. But there is two different types of osteomyelitis. What kind of osteomyelitis in this case will cause sclerosis? Good. Chronic osteomyelitis is what can cause sclerosis. The other, acute osteomyelitis, will cause a lytic lesion instead. That is a key difference. Okay. What are the other things? What else can cause sclerosis? Mets, exactly. And they're specifically osteoblastic Mets. Not very common. Okay. Yes, there are several malignancies that can cause osteoblastic Mets, but they are very rare and they'd rather cause osteolytic Mets instead. What else? Think about other bone pathologies. We've said osteomyelitis, that's a type of inflammation. Well, there's definitely one type of disease. Oh, okay, yeah, fine. Yeah, I know the one you're talking about. Paget's disease, excellent. There's also another one, Ewing sarcoma, but other primary bone tumors as well. Exactly. And here we go. So these are the broad category of conditions that can cause sclerosis to the bones. Okay, so you have a look at this. It's a very, very unspecific kind of an X-ray. If you look at the humerus, there's a bit of lytic plus blastic lesions. The ribs are predominantly osteoblastic. What can we pick up from here? What do you think the diagnosis can be just by looking at it? Tumors, yeah. Marble bone disease, yeah, it could be. But the point I'm trying to make here is that without any further information about what the symptoms are, we can't really identify anything else, really. Okay, so I'm going to give you this. this is the case. 64-year-old male, no past medical history, chronic weight loss, diffuse chest pain, and differential. So this is obviously prostate cancer, but any other differentials that you might think of? Osteoblastic metastasis. There are a couple of malignancies that predominantly, I know I said that they're a bit rare, but there are a couple of cancers I can think. Yes, tuberculosis can be, particularly if you're talking about abdominal tuberculosis. Any other specific cancers that can cause osteoblastic? Breast, for sure. If we're talking about younger cases, we can think about neuroblastomas as well. We can certainly also think about neuroendocrine tumors. So by that, I mean carcinoids. They can definitely cause osteoblastic metastasis as well. So what I'm trying to say is that, yes, you can describe the X-ray as osteoblastic lesions, and there's definite hypersclerosis of these bones and so on and so forth. But the point is that if they are diffuse and they're located in more than 2 ribs, then we really don't know as to where the systemic condition is coming from unless we have more information. So what I'm saying is you can't just rely on the chest X-ray to rule, yes, it's one diagnosis. Okay, right. Lytic lesions. Now, I'm not going to dwell too long on the lytic lesions. Now, these are the opposite of sclerosis. So you have a decreased density of bone. What can causes be for lytic lesions? Give me a couple of causes. Yeah, good. Basically, any kind of malignancy. Also, in this case, it'll be good. Acute osteomyelitis. Well, Emily picked up on that. Multiple myeloma. Excellent. Okay, so these are the main things. At the same time, Paget's disease is also known to cause some lytic lesions. There's a, it is kind of like a bifold disease. It can definitely cause lytic lesions as well. So bear that in mind as well. Okay. Okay. What do you see here? Anyone tell me? Yeah, good. Well spotted. But what is the abnormal feature, if there is any, an abnormal feature that you see here? It's a very, 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 very rare finding. Don't think of it. You will cause yourself a lot of trouble. Okay, so for all intents and purposes, the X-ray is of good validity. It's of good quality. Okay, the airways are fine. They're in the middle. There's no deviation. There's no narrowing. There's no foreign object that I can see. Now let's look at the bones. What do you see here? I've only ever had to face about 3 of these cases, and I've had more than my fair share of having looked at these. Surprisingly, they present themselves quite late. A bit odd. Let me try. No idea. Okay. What's that? Cancer. So we've just stepped it all the way up to cancer. I've highlighted over a few. What is that? It's that weird bit of thing over there. Does anyone know? Ooh, fracture of the first rib. Remember, look at the features. Is there any features of the ends causing sclerosis? No, there isn't. There's just a blunt ending. You're right. It might be the first rib, but is it really the true first rib? Am I confusing you more and more now? Right. I'll just wait for Amir to frantically stop. An extra rib, exactly. Is it considered is that they'll just come up on you out of nowhere and when you're least expecting it. Okay, so in this case, I had a patient. She was 38 years old, and she was complaining of intense pain, paresthesia, and weakness on her left upper limb. Okay, and this is not her X-ray, but I tried to find an X-ray that is very close enough, and she had a left-sided cervical rib, and the syndrome that it causes is, as rightly as you mentioned, is thoracic outlet syndrome. Exactly. And thoracic outlet syndrome can manifest itself in a variety of symptoms. So mainly it's it can develop into neurology if the brachial plexus is very badly compromised, and at the same time, doesn't matter at what stage they're in, it is an emergency and you do have to treat it. Now, like I mentioned before, they are very rare. I'd say the probability of people having them is about 0.5 to 1%. It's more common in women as well. But the main thing is that it is still an emergency and you do have to act on it quite quickly. At the same time, most people can even go through life without even noticing it's there. Okay, so last one. What do you see here? We talked about bones, and remember the B in ABCDEF stands for bones and soft tissue. What do we see here? And you have to always evaluate this as well. Good, excellent. It is subcutaneous emphysema. Is it widespread everywhere? Yeah, it's definitely everywhere. A little bit of a background for this lady. So she is a 70-year-old and she had a radiation. Why do you think there's radiation? It could be radiation, could be that she had a neoadjuvant therapy. In this case, I'll go through the causes of the actual of subcutaneous emphysema. In this case, we have a 70-year-old lady, and she has diffuse subcutaneous emphysema, and the reason for that is because she had a right-sided lung resection. So now that's why you can't really see the borders of the right lung that clearly. Okay, there's also some pneumothorax, but the pneumothorax is kind of blocked out. Subcutaneous emphysema that you can see all throughout on the right hand side. An interesting sign that you have to note is that when there is subcutaneous emphysema and there is no real tissue that the x-rays can be absorbed at on over where the lungs are supposed to be, you can really visualize the pectoralis major fibers, and you can see them really well over here. Now there is a specific sign that you call this. And the reason why you can pneumothorax that well is because the subcutaneous emphysema kind of digs into where you can spot the pneumothorax quite clearly. And this sign is called the ginkgo leaf sign. God knows who named it like that, but that it is the sign. And you can see that very clearly towards the edges of the right pleura. Okay. Usually what we'll expect the subcutaneous emphysema to be absorbed by the body, and it should generally go away by itself. There are cases where it doesn't, but in those cases, surgical intervention might be necessary. But again, the risk is that you might be exposing them to even more air to enter. Just want to finish this section off with the fact that subcutaneous emphysema can be caused by internal means. It can be caused by external means. Does anyone know what the internal means of causing subcutaneous emphysema can be? What can cause subcutaneous emphysema from an internal aspect? Cancer. Is everything cancer of the floor? Common is common. Gliomas all. Pneumothorax, there we go. Pneumothorax, pneumomediastinum, pleural interstitial emphysema. Remember, guys, common is always common. You will not be dealing with mesotheliomas on a regular basis. The one time that you do encounter it, it'll be, oh my God, but it'll be very rare as well. Okay, and mesothelioma will often present with other signs. Okay, so pneumothorax, pneumomediastinum, pulmonary interstitial emphysema, these are the things that are the obvious internal causes of subcutaneous emphysema. Externally, what are we thinking of? What can cause external subcutaneous emphysema, where air is introduced from the outside, not from the inside, but from the outside? If someone says cancer again, I swear to God. Good. Okay. Good. Didn't get the forgetting your anniversary reference, but okay. Penetrating chest wall trauma, post-surgery, any kind of chest tube placement that you then take out, revealing the actual hole that left over, and that can also cause subcutaneous emphysema if the air goes in between. Okay. And finally, this is quite rare. It usually presents not over the chest, but rather over the legs and over the abdominal wall itself. Final thing is if the air itself is produced in situ, and that is if there is any kind of necrotizing fasciitis kind of a thing, which you'll be surprised to know it is quite common in a general surgery setting, and that can cause gas gangrene. But it's quite rare when we're talking thoracic wall, sorry. Okay, so we've now kind of covered both airways. We've kind of covered what the most common pathologies are in both of them. Let's carry on with cardiac slower. Now, before we go into cardiac slower, I'm just going to give you a quick 5-minute break. Okay, is everyone okay with that? Yes, no? No one's bored yet? So the reason why I'm going to finish off in about the next couple of slides really is that I'd rather leave enough presentations for the remaining lung pathologies to be covered. So I feel like I need to cover them in a little bit more detail rather than going on for like another 2 hours. I'd rather finish after cardiac pathologies. Okay, so we'll let, yeah, okay, fine. We don't need a break then. So we'll just go over to cardiac pathologies, the cardiac silhouette, as well as the mediastinum. Okay, so what are we thinking of when we're thinking of any kind of pathologies that we can identify in a chest X-ray for cardiac and from a cardiac point of view? So essentially what you're trying to say is, oh yeah, sorry. So before we go ahead with that, this is essentially the cardiac silhouette. Okay. There are certain landmarks that you need to be aware of, and these are them basically. What they code for. This was covered in last week's topic, but essentially these are the main features that you need to look for. And if there are any changes in these features, then you know that there is a pathology present in any one of them. Okay. Okay. In terms of the actual pathology itself, the main features. We talked about position and size, so essentially cardiomegaly. Okay, what else? We can think about really truly cardiac. It's caused by a pressure that might be originating elsewhere. Okay, so I'm talking about true cardiac pathologies that can cause features of basically features of the cardiac silhouette, really. Right ventricular enlargement. Okay, pericardial effusions, and finally mediastinal masses as well. Okay, right. So these and the hila signs as well, which we'll cover as well. Right. Okay. Cardiomegaly. How can we define cardiomegaly as? What do we have over here? Number one, is it an AP view or is it a PA view? Good, well done. And in this case, is there a cardiomegaly? Right, so that was a trick question. Good, Moina got it. Moina got it. So we can never ever evaluate the size of the heart on AP. Okay, we have to always look at the PA. Always has to look at the PA. All right. So here we have a PA view, and you can see how much more oblique the clavicles are in this. Okay, and this is true cardiomegaly. Okay. If there's one thing that you need to remember is that cardiomegaly is only evaluated on a PA view. And the reason for that is because when you're firing the X-rays towards the subject on a PA, the heart is closer towards the detector. So therefore, the deflection of the X-rays on either sides of the heart, it won't be as much. So therefore, you'll get a true size of the actual heart itself. So, and you mentioned this before, it's a cardiac index. It's known as a cardiothoracic ratio. So we measure two different things. We measure the maximum width horizontal heart, and that's divided by the maximum thoracic width. So in the first one, we can confidently say it's probably about 40%. So therefore, don't have to really worry about anything. But at the same time, as I mentioned, it's an AP view, so we don't generally tend to do that. Okay. The second one, that is where we do it, and it is definitely greater than 50%. So we can confidently say that there is an element of cardiomegaly in this case. So just a quick recap on what cardiothoracic ratio means. It's just maximum cardiac width over maximum thoracic width. And remember, it's only valid on PA films, and make sure that you check whether it's a PA or OP. There are so many cases, and this is something that a couple of my F1s have done as well. And they basically just read the X-ray wrong, and they were suspecting cardiomegaly. And we found out that that X-ray was done on a patient that couldn't make it to the X-ray department itself, and it was an AP view, and we cannot assess cardiomegaly like that. Okay, just out of interest, does anyone know any causes of cardiomegaly? Congestive heart failure, good. Yeah, you know what, I'll give you that one. Okay. So any kind of heart failure, okay, any kind of heart failure, left-sided, right-sided, any kind of heart failure can cause it. Of course, any kind of dilated cardiomyopathy, hypertrophic cardiomyopathy, any kind of cardiomyopathy, okay? So all these can cause or will result in cardiomegaly. And remember, there's one thing that you should take away from evaluating the heart. Always make sure that it is a PA film. Okay, right. Left atrial enlargement. We've already covered this. We already know one feature of left atrial enlargement, and that is the splaying of the bronchi. Okay. There are a couple of other features as well, and there's one specific feature that you need to look for. And admittedly, it's not very easy to spot in every single person. Okay, but it is definitely one that you do have to, you should see, and that is that right there. Okay, this is known as the double density sign. Does anyone know what this double density sign means? It'll inevitably, remember, any kind of heart failure, sided heart failure will lead to the other sided heart failure as well. So you're right, it can be big as well. But in this case, the right atrium is pushed because of the left atrium. Yeah, there is mitral stenosis. Good. But in this case, the purple, or the lilac, if you want to call it that, the lilac curve itself would be the right atrium, and the red would be the left atrium. There's a shadow of the left atrium. Yep, exactly. That is a shadow of the left atrium. Okay, so what can be the causes of left atrial enlargements? Before he mentioned one of them, Amir is very, very proactive. Good, okay. Anything else? Good, mitral, so mitral valve diseases, so mitral prolapse stenosis. And in this case, what do we have over here? We can see it very, very obviously in the X-ray. This person must have significant heart failure, has been having significant heart failure for quite a while. And he was also treated on, because you can see a specific feature in this. And what is that? What's that ring over there? Let's see. Yep, it's a prosthetic. Yeah, it's a valve replacement. Exactly. Okay, so in this person, he had a valve replacement, and despite that, he still has an, a massive left atrial enlargement. Yeah, exactly. Well done. Okay, right ventricular enlargement. Now, this is a bit tricky. Okay, and the reason why it's a bit tricky is because most often, as a junior doctor, you request only an AP X-ray or a PA X-ray. Okay, it's very, very hard to prove a right ventricular enlargement on an X-ray on a PA view. So you need to request a lateral view as well. It's generally good practice that if the patient can make it down to the X-ray department to request a lateral view as well. Okay. The reason why I'm saying this is because, yes, there is some evidence that they're thinking that would be pathognomic for right ventricular enlargement. However, they're not always common. So the standard is PA and lateral, AP only if they're immobile and if they genuinely cannot make it. Okay. But like I said, there is some evidence on the PA view that would indicate towards right ventricular enlargement. But ideally speaking, they're not conclusive, neither are they pathognomic. So a couple of the evidence and stuff is just that obviously you'd have to have a higher than 50% cardiothoracic ratio, which would indicate cardiomegaly, and that's usually something that the right ventricular enlargement would cause. There's another thing called rounded apex and elevated diaphragm. I'm not too I don't buy that easily because it's not really specific for it. And there's also this acute cardiophrenic angle. Now, if you remember my last lecture, I told you to focus specifically on the costophrenic angles and the cardiophrenic angles and evaluate if they are acute or if they are blunted. Okay, they're saying that an acute cardiophrenic angle as well could hint towards a right ventricular enlargement, but the best view is always in a lateral view if you want to prove right ventricular enlargement. Now, before we go into seeing what I mean by that, any causes for right ventricular enlargement? What can cause right ventricular enlargement? So, by the way, the reason why I'm asking you causes, I know that you just want to look at X-rays and see the signs and things, but at the end of the day, you have to also relate whatever it is that you want to, whatever it is that you, perfect, exactly. Whatever it is that you interpret, you have to always relate it back to symptoms, and particularly if you are the doctor looking at the patient, you need to feed it back and you need to enter that to the radiologist. Exactly. That's basically what I was trying to say. Good. Right. So this is have a completely normal person having a lateral view of the X-ray. There might be some evidence of vertebral disease, but overall, in terms of the heart, it's fine. Okay, and the reason why I say it's fine is because you have to look at the retrosternal space. Unlikely to be PE. You can't really detect it in PE. You can't really see a PE on X-ray. Is that what you mean? The UIMS team.
No, I meant PE can also lead to right ventricular enlargement.
Oh, yeah. No, of course. Yeah, absolutely. So any kind of pulmonary hypertension, any kind of pulmonary congestion, all these can ultimately result in right heart failure and thereby right ventricular enlargement as well. So essentially cause cor pulmonale. So in the lateral view, what you have to look out for is the retrosternal space. Now, the retrosternal space on the left in a normal X-ray, a normal lateral X-ray, is empty. There is nothing there. Okay. By nothing, I mean there's fluid over there, but there's nothing else going on over there. In true right ventricular enlargement, you won't retrosternal space. It's completely covered by the ventricle. Okay, this is more conclusive that there is definitely a type of enlargement than anything else. Right. Very quickly, and I'm going to leave it for now, and I'm going to go through the rest of the things and the rest of the views in next week. Or would you want to continue this at a later point during this week, or would you want it to be done next week instead? And if so, what day would you prefer this to be done? Next week. Perfect. That's fine with me. I can definitely finish off the rest of the next Tuesday. Fine. You're fine with anything. Okay, so basically, just to finish this off, pericardial effusions, they are very, very hard to differentiate, okay, between an effusion and cardiomegaly. You need to have, like I said, it's always good practice to request a PA as well as a lateral view, okay, because there are some things you need to corroborate lateral view in order to make sure that it is definitely what you're thinking of in a PA. But regardless, due to the fact that the heart itself has got essentially 3 different layers around it, and by 3 different layers, I mean the pericardium, the endocardium, and the myocardium in between as well. And even with that, you have epipericardium, the endopericardium as well. There is a lot to, there's a lot of signs that you need to pay attention to. The most common signs that you need to look for are the PA, and the PA view, the water bottle sign, which is this beautiful image, and the Oreo cookie sign. I am going to show you the Oreo cookie sign, okay? But before I'm going to show you, I want you to have a look at it and try and tell me next week. Okay? So does anyone have any questions for me at this moment? Is everything clear? Do you like the format of what I'm trying to go with here? Okay, so with that, I'm going to end it for now, just so that you won't get any more. We'll get there. We'll get to more cancer cases. With that, I'll end it for now. Okay. Hope that was a little bit more useful. I know that the main pathologies will still revolve around the lungs, but that is why F is at the very end. It's because you need to go through all these before you identify any pathologies in F. Okay. Right. Thank you very much for listening, guys. I will see you all next week. Okay. Yeah, I think Preetika can answer that for you. Thank you, and I'll see you guys. I'll see all of you guys next week. Okay.
Thank you for attending. Could you guys please fill in the feedback form? I've attached the link in the chat box. If you want more cancer cases, then you can put in the feedback form. We'll work on it. And after you fill it, you'll get a certificate of attendance. So make use of it.
If anyone has any questions, just shout them out right now, and I'll try and answer them to the best that I can for the conditions that we've talked about just now. Okay. Yeah, sure. I think you can send messages privately. Is that right?
Yeah, I can.
Yeah.
It's not about the necessarily the content today, just more of a general questions.
I'll try my best.
We have our next lecture on abdomen X-ray, which is next Tuesday at 7 p.m.
Yep.
So if you guys are interested, we hope to see you again.
And spread the message. Definitely. Thing I think I mentioned